Great, good morning, and thanks for joining us. We're leading a panel today on mainly on integration and looking at health IT adoption. I'd like to introduce the panelists. We have Rebecca Chiu from MedHelp, Matt Douglas from Practice Fusion, and Shadaab Kanwal from Kaiser. I'd like to give each of them a couple minutes to introduce themselves, give you a sense of who they are and the companies they work for, so you understand their perspectives.
I'm Rebecca Chiu from MedHelp, coming from a VC and consulting background, and been doing business development and corporate development in various companies in terms of pushing the next level of growth in different companies in different industries. So healthcare is definitely something exciting, interesting, and very meaningful for everyone. And in terms of MedHelp, we're the leader in terms of consumer health engagement. So there are three parts to the business. The first is to connect with patients, with other patients like them, to gain insights, to crowdsource the best treatment options for them. We have about 12 million monthly visitors to our site every single month. The second part of the business is we partner with 7 of the top 10 hospitals in terms of answering questions on our site for free. So it's a great way to market the hospitals as well as the doctors, and then at the same time giving fantastic advice to the consumers. And we also have a data platform where we pull in data from wellness mobile apps that we develop, from health devices, as well as our online trackers, to aggregate all of that information together, and for health plans, retail pharmacy to build solutions on top of that.
Good morning. My name is Shadaab Kanwal. It's happy to see so many familiar faces, and thank you, Will. It was an excellent presentation. So, as usual, good to partner with you on that. My portfolio at Kaiser Permanente is research and quality, and although it's an abbreviation of a mouthful of areas that my team support, which are community benefit, research, health policy, international health, clinical and hospital care delivery excellence. So the technologies that are rooting in these areas and the innovations that are taking place in these areas, my team helps the physicians, the care delivery partners, and the clinicians to excel in those areas. Most recently, my last appointment was at the UCLA Health Sciences, and my role was in clinical informatics, where we excelled in delivering the care and the analytics together for the academic medical center. The passion to be in this environment, and I'm thankful to SVF for creating this opportunity and to have a dialogue and with so many folks who are involved in the delivery of care and yet bringing the technologies to make the delivery of care. So my passion is in the development of data to information and generating knowledge out of it. So welcome to all of you.
Thanks, Shadaab. So my name is Matt Douglas. I am co-founder and current VP of Engineering at Practice Fusion. We are a free web-based electronic health record for doctors to manage their patient populations, and free personal health record with Patient Fusion for patients to manage their health. We started the company in 2007, and we now have about 38.5 million patients under management, 160,000 registered users, and we're managing about 2 million patient visits a month on our platform right now. We've become quite a bit more than just an electronic medical record at this point, even though we're top 10 for attestations for meaningful use in 2011. We're now more of a healthcare platform, allowing labs to connect via APIs that are actual 21st century APIs, not HL7 old school broken concepts. We have many devices and mobile applications plugged into our Personal Health API. So we're innovating in a number of ways as far as connecting patients to their physicians and physicians to each other on our platform.
Great. So just to kick it off, data is a hot topic these days, and obviously we're generating much more data in the healthcare field than we were previously with the adoption of technology. What do you see as the greatest challenges in integration? Is it a demand issue, or is it structural?
Let me take the first one on it. The current generation of health data is basically, or the system data is from the encounter-based data, or when we arrive at a facility and basically offer our information. So those procedures and medications that result of that encounter basically enable the data. The data is becoming bigger and less structured. So I think the biggest challenge here is the manageability part of the data, how it is exponentially growing, and at the same time how it is going to be managed during that process. So the complexity of it is that the areas where the data is growing, there is standardization that is available, but at the same time there are proprietary issues within the data that still takes place in terms of the manageability part of it.
Also, the other thing I see is partly structural. In terms of health system in general, it's fee-for-service. There's a lot of silos just even within the provider space. There's silos, separation, data separation between the health plans, the providers, as well as what consumers are collecting. We're speaking to a couple of health plans as well as retail pharmacy to see what could we do in terms of taking that consumer collected data and really empower them to individualize, customize their message to that member or to that patient. But a lot of times priorities are different. So within the provider space, they're focusing on more EMR integration in terms of how to get that data to be more centralized within the organization. So that's one of the top priorities. But in a lot of ways, the patients have to figure out a way for them to empower themselves to do the right thing in between the visits. That's a continuous process, and having that dialogue is really important for the patient to do the right thing.
Just to add one thing, it should be offensive to everyone in this room that we can't really even talk about integration or interoperability yet, because at least in the outpatient space, we're talking 550,000 physicians. 82% of them are still on paper to some degree within their practice. So we can't integrate paper. It's just not going to happen, right? The faxes don't provide any sort of integration. They end up just resulting in another piece of paper. So the first thing we have to do, which the Office of the National Coordinator is pushing very heavily, the Obama administration made a major investment in this with the American Recovery and Reinvestment Act, which is essentially to bribe physicians to adopt systems that historically have been too expensive. And there are market pressures on those very expensive electronic medical records to lower their costs, to make it easier for doctors to get started. So until we have some sort of critical mass there, maybe it's just 30% of the market converted to a full EMR that can interoperate. Or that at least is storing things in a structured way that can be extracted later. We must hit that critical mass before any of this is real meaningful. Until the people in Middle America and areas outside of the coast that tend to be more connected and more early adopting of technologies like this, and until we hit that point, those patients are still going to be going doctor to doctor, filling out paperwork over and over again. Medical errors are going to continue to be made because their allergies to the medication that they're about to be prescribed is locked away at their primary care that they saw 3 years ago. So we've got a lot of work to do on the just getting doctors to use electronic systems front.
So you don't see value in trying to interconnect the systems that are already up and running?
There's great value in laying the foundation and laying the groundwork in connecting these systems. Merely what I'm saying is that there won't be wide use or adoption of those integrated systems until we have some sort of critical mass, that it won't actually impact patient care to the degree that we need it to. And that will actually probably result in people sort of poo-pooing or naysaying the adoption of systems because they won't see an immediate benefit from it. So we really need to push this thing quicker than it's going. Attestations for 2011 meaningful use were, well, the Office of the National Coordinator may disagree with me. I think they were pretty low. I thought it was kind of a disappointment, the number of physicians that attested. So we just need to move this thing quicker. And in the meantime, you're right, building that foundation under the covers, connecting systems, finalizing the standards that those systems are going to connect is something that still hasn't happened yet. We have the promise of HIEs, but there's very little HIE integration. Health information exchanges, sorry, I speak in acronyms, especially early in the morning where my brain's not functioning. So those are coming to the forefront, but there isn't great adoption across systems of HIE and connectivity, and the incentives aren't greatly aligned for hospitals to talk to each other, for EMRs to talk to each other. There's still all this data kind of siloed away, and there's a bit of a tug of war concerning who owns the data, how much is that data worth, should they give it away for free via an HIE. That'll all be determined with stages 2 and 3, I'm assuming, of meaningful use, if that actually makes it.
So looking at those integration challenges that we were just talking about, is the answer to accelerating them further regulation and reform, or do you think there are market forces to bring to bear?
I think a lot of it's in place already with the bribes, with the subsidy, I guess is a more PC way of putting it, where the federal government has stepped in and said, I'll give Medicare physicians who are seeing Medicare patients $44,000 over 5 years to adopt the system. I'll give doctors who see Medicaid patients $65,000 over 5 years. That's a good start, and it's because of that bill, because of the stimulus bill, that Practice Fusion even exists. And so because of that, we now have a very, very low cost, in our case free. There are other models like us that are web-based that are fairly low cost, taking advantage of the economies of scale of the internet to drive the cost down. Those systems, and I'm a bit biased here, but those systems are the only way that we're going to see great, vast adoption across the entire country.
We have a question from the audience.
Could I?
Go ahead.
Okay. Have you ever thought of maybe the model isn't right? That's why you haven't created a critical mass. Although you are an improvement over her model, but still that's not good enough. That's why. And right now, are you actually government funded? Because you don't charge people.
No government funding.
Matt, can you just repeat the question?
Yeah, sure.
So that everybody can hear?
She is asking, and correct me if I'm misinterpreting, is asking if the web-based or advertisement-supported or low-cost model is sustainable or is actually the right way. Yeah. So
Government funded.
we are not government funded. The money goes to the physicians directly. The reason that we exist because of that funding is because of the stimulus bill is because that immediately garnered interest within Silicon Valley venture capital to invest in companies like us. We were well positioned to take advantage of it because we had created the technology. We just needed cash to get it off the ground. It's a reverse model. We are not asking physicians to pay for the product because we think it's a failed model. The reason that we have such low adoption in the country, 3 years ago, it was more like 12%, 7 to 12%, and now it's like 18%. So it's accelerating. This incentive has only been in place for about 6-7 months. I guess back to October was the time that doctors were really getting started, and they didn't see payouts until January. So we're right on the cusp of that. But there really should be more and more happening now.
But my main point really is the point that maybe that model is still not good enough, all right? There are better models.
It's not enough to be free. I would argue there is no better model than being free, and in being web-based.
I have one.
Okay.
But my point is, though, that it's not enough to be free. It's got to be free, it's got to be accessible everywhere, and it must be easy to use. Those all have to sort of converge.
Also, just to add to that, in terms of on the hospital side, obviously there's a lot of challenges and structural issues, but consumers today, patients today could collect data. So for instance, we have I Am Expecting, which is a pregnancy app, and people could track exactly what their symptoms are from week to week, from a longitudinal perspective, and we help them to gather that data, aggregate it, and say, during week 31, if you're still going through vomiting, only 2 to 3% of the people are going through that. And that's pretty rare, and that could be a sign of a serious problem that you want to explore. So by unlocking that data from a consumer end, if your application is really engaging, it provides value and insight, people will track them. Partly why Google Health hasn't really taken off is it's just a data dump. There's no insights from that. So really thinking about ways that you could unlock that data and provide really useful insights for people could also empower people just from their own standpoint.
It actually leads to the next question I have, which goes back to something Shadaab was saying earlier. How do we avoid the data dump? We're generating so much more data. It's stored in, silos, whether it's your, wherever your blood pressure monitor is reporting or whatever. How do you make that data meaningful? How do you make that presented in a way that makes a difference to the care provider or even the patient?
So the care provider in the space that we are operating nowadays is basically looking for remote, virtual, and manageable data kind of capabilities. And to manage that data capabilities, we have to provide them of the contextual aware data, which basically means that if there is an ambient findability prospect that we can add to that data part of it, that brings it all together. And what I mean by ambient findability is that when we from an encounter perspective, when we come to a point of care, that at that point the data that is relevant to the point of care setting is enabling the physician or the clinician to take care of the clinical process. Now granted that the data acquiring devices or the data acquisition points are so varied, and to harmonize that is a particular challenge. So one way we have been able to, at least and using Will's slide, from the proof of concept to the point of delivery part of the innovation is through an electronic health record. And nevertheless, we know that the electronic health record does not have all the complete data because it's not captured at the right point of influence where the data can be aggregated. So I think the manageability part of it is where we have to kind of still work towards those areas that facilitate those processes, and the aggregation of that data to be converted into that information is still to be worked out.
Did you want to add?
Also, in terms of the data within the hospital walls, some of the things that we do, the number one desire for those patients is actually to communicate better with the doctors. So we provide ways for them to present what they're going through between visits more effectively to those specialists. So the last thing that also the doctors want to see is a data dump. So we provide very specialist-focused data to each of those doctors as well, so you could see exactly what the patient is going through. For instance, pain tracker we have, you could track location, severity, duration of that pain, and bring it into your doctor's office and play it back like a video. That's a great way than saying, oh, there are better days, worse days. It's a very objective way in terms of conveying to the doctor, much better in terms of what you're going through. I think a lot of times doctors have only 8 to 10 minutes with a patient, and a lot of times it's a one-week conversation. So any way that the patient could be empowered to communicate in terms of their condition better to the doctor is really helpful. And on top of that, our Moody Me health app as well, it tracks people's mood from day to day, make it really engaging to track for people. A lot of times medication for mental health is going to decline over time, and that could be a great way for them to have an indication that the medication stops working, and for them to drive them back to the doctor's office.
And to that point, because the physician only has 8 to 10 minutes, sometimes less, depending on how many patients you're seeing in a day, and how many you need to see to stay profitable, that data needs to be flowing to the doctor at all times. And whether the doctor has time to look at it, or she is busy seeing patients, or, heaven forbid, has a personal life, that information needs to be flowing into that practice's EMR so the data is available when the doctor does have time to take a look. And then we can start applying really smart algorithms to that data flowing in. So, we're building out our platform that will allow devices and mobile applications to pump that data into our ecosystem. We will additionally be adding algorithms on top of that, for instance, every morning when you step on your Withings scale, it's a Wi-Fi enabled scale, you authorize that information to go into your EMR or your personal health record. Preferably they're combined, so your physician has access to the same data you have access to. That data would then flow in incrementally every morning when you step on your scale, and if your scale reports a weight 10% higher, or whatever that threshold is that the physician set for that particular value, then the doctor receives an alert. And that we have a real opportunity to innovate very quickly and unlock great preventative health care aspects here that are just unavailable right now, because all that data is locked away on that scale when you step on it in the morning. It's locked away on the blood pressure monitor you're on, or your blood glucometer if you're diabetic. So unlocking that data is first and foremost making it visible and representative in a visual way, so the physician can make a good decision, is also very important. But I would say that that's a very, very far, way down the list in terms of, what we need to do first. Unlocking the data is the biggest hurdle. Then, we can iterate on that and try not to solve this entire feedback loop in one fell swoop, but we tackle getting the data in first. Then we can allow the physicians to communicate how they'd like to see it. Just getting access to the data is first. We're very much in the dark ages of data access as far as managing patient care goes.
Also, in terms of just getting data into the system, I think the last thing that doctors want is wrong data or data that's not relevant that they're liable to see. So what we really focus on is things that will make a huge difference. For instance, if you step on that scale, you're congestive heart failure patient, then in that case, that could be a sign that you have fluid buildup, and that could be critical for the hospital to manage. So getting the right kind of alerts so people are not liable, and at the same time, as the ACO model evolves, they really have an incentive to get that data. So I think it's great to unlock that data, but only the relevant bits, so people have an incentive to adopt that, is really critical.
There was a question in the audience.
Yeah, along those same lines, obviously for property insurance you get a discount if you have fire alarms and those kind of things. Are we getting to the point where, at least for more chronic disease management, that you're seeing any of the payers offering any kind of incentive to people to, go ahead and hook that heart rate monitor up, if they can provide blood pressure information, that kind of thing, probably?
So from wellness,
we'll repeat the question. So the question is essentially, are you seeing incentives from payers and others to get the patient, if you will, to use technology to feed the data back into the system?
From a wellness care perspective, yes, there is incentives, that are built along with the partnership with the employer-based organizations, where the incentivizing the patients to participate in healthy habits and cultivate those within their families, and yet eventually there is a result of those trendings that come back as an outcome-based approach. So yes, there are not really too many tangible, from a consumer health perspective, like benefits that are really coming out, but the value of it is absolutely realized when the enough data is collected to demonstrate the trend in terms of negotiations with the contract rates within those employer groups. So there is prospective work that is getting more and more, progressive in that area?
Sure, go ahead.
This might be a slight change in topic from what you have in mind, but there are enormously useful examples of things done in other fields that are relevant to this issue of innovation and its integration and diffusion and so forth. Have you looked at it? Let me give you one example. A bunch of years ago, I was a professor at Stanford for many years, and a bunch of years ago I had seminars when the new hot topic in the information technology world was enterprise integration. There's a tremendous amount to be learned, and there's a great similarity between what they worked on in enterprise integration and the issues that you're talking about at this conference. There's a great deal to be learned, both positive and negative, of how to deal with the challenges that you're already discussing from some of these other areas. And I seldom hear in the discussion of these strategic comments work that people have done to mine ideas and experiences from these other areas to help us speed the diffusion of healthcare technology. Has anybody any thoughts on that?
Can you give an example of a successful enterprise integration?
Pardon me?
Can you give an example of a successful enterprise integration?
That's my point.
Outside of healthcare, can you give an example of one?
That's my point. Next 12 years.
So
You want me to clarify?
Yeah, so I can respond to it.
There was a tremendous amount of interest. There was a lot of concern for many of the issues that you're talking about with more data, better integration, and there were all kinds of problems that arose once the facts of real life in the private sector as well as government began to be clear, that led to many of the ideas failing because they weren't recognizing things that had been done. So if you don't think there are any positive examples, okay, that's fine with me. I'm not picking that argument. But there certainly are examples of things that were done wrong, and I'm not on the panel, so I'm not going to try to do this to you. There are things that you could certainly point out are similar to mistakes that were made that led to failures in enterprise integration.
So I was just curious what one of the successful ones that you know of so I can speak to it.
Did you hear what I said? I just said my point doesn't turn on that, and I will take. So, okay, I'll play your game. There's a field called enterprise integration. There's a company called Enterprise Integration Technology. It was led by a guy named Marty Tannenbaum and some others. They had some very good ideas, and they made an enormous amount of money and installed in a lot of places, and some of their stuff is still being used. Now, that might not count as a success to you, but it counted as a success to them.
Okay, so do you know what systems they were connecting? I'm trying to draw a corollary so I can answer your question.
They developed their own enterprise integration systems. It was database-oriented. It integrated information across the business organization so that it would help the people making decisions do a better strategic job of making the decisions in the face of relevant information.
Okay, so you're still pretty abstract.
So I think the question.
Commerce One.
The question really is.
Commerce One, with the beginning of for example, EDXML doing business transactions.
So just to put things a little bit in context, in a lot of other industries, there's not as much regulation. It's a little bit more uniform from one client to the next. Within a hospital system, some of the largest hospitals, you have 200 different hospitals potentially, and each of those hospitals have silos according to specialties, and all of them have different business processes. So I think there are certain challenges within healthcare that each of them could potentially have ingrown within each of those hospitals. So it's much more difficult to do the integration. Not impossible, obviously. Epic has done that, in terms of 130 million, covering 130 million people, and they're trying to run disease management initiatives across as well. But within healthcare, it's just a much more complex system with a lot more stakeholders that you need to align the process. Probably much more challenging within healthcare.
And with Epic, different Epic installations can't even talk to each other.
Right.
So that's a serious problem. But there are some regulatory pressures, but I don't think they're prohibitive at all. There's plenty of opportunity to innovate and create companies in this market that will drive this forward. I don't think that those are prohibit that much. But the issue is that with within healthcare, there is no great incentive right now for hospitals, different hospital systems, to speak to each other. Whereas within commerce, within a standard enterprise company, they tend to want to talk to each other because they're doing business. But hospitals don't, right now, they're not really doing business with each other. They're managing a patient population that is traversing between the facilities, and that's where where there's a bit of a breakdown in the analogy.
Let's add a few more voices here. I see a number of hands in the audience. Go ahead.
Actually, as we're talking about hospitals not having incentives, I would say vendors don't have incentives. This is not a issue of who's in control. Because all vendors will facilitate, I can import all of the data, but I cannot get my data. And it was an interesting story. I was talking to a friend who is a doctor, and he is, let's say, skilled in informatics. And one of the questions that he had for one of their vendors was, why are you selling us all these machines that don't talk to each other? Because they can get a high diagnostic piece of equipment, but you cannot import data to their ER system. I said, no, because we are buying them. So, I mean, what are we going to do about those things? Our incentive is really to push for standards, for open standards, so that everybody can actually, we can have a benefit of best of breed. So that right now there is a lot.
There are supposed open standards right now that very few systems can talk to each other on. There's HL7, which I would argue is not really even a standard, because you see 100 different HL7 implementations, and you see 100 different HL7 standards, sometimes more than 100. So it's structural to the way that systems are communicating. We have these standards right now. We have these technologies. It's called XML. It's called XSD. There are XSLTs. I know I'm throwing out a bunch of acronyms, but these are standard internet, modern standards for communication, and that hasn't really taken hold in healthcare. And when you say the vendors are not incentivized to communicate, there is absolutely no incentive to communicate. In fact, there's a disincentive. The HIEs expect vendors to pay to integrate. So it's lined up directly in the face of what we're trying to accomplish here, which is more systems talking to each other. Further stages of ONC meaningful use certification will drive us in the right direction, but that's because the industry itself has failed to come up with a model that will work. And that's a model that will work between hospitals and outpatient, between outpatient and outpatient for managing referrals. And I would argue that because of these newer web-based models that are coming to market, that is the way that the masses are going to be able to communicate. If we have 5 or 6 strong platforms in the country all interconnected, that will drive that interconnectivity.
So my question is, we've talked about the care providers and whether or not they have incentives and what their hurdles may be. We brought the vendors into the equation. What's the role of the consumer or patient in generating, managing, having access to this data, and is there a model of incorporating greater consumer participation that drives the rest of the system to adopt?
I think just even from an e-patient perspective, allowing for patient to have a voice in all of this will start driving in terms of market changes. So one of the things that people have done is from the employer side, from the patient side, people said, I'm basically own my data and I could unlock it to whomever I want to reveal this information to. I think that's a first step. And then the second thing is there being a lot of trend toward patient-centered care, having that patient be a critical part of the care team. I think that will start aligning people in terms of saying, okay, this patient is really important, and the customer satisfaction perspective that we're linking our reimbursement for Medicare for is really important. I really need to take notes. And then on top of that, for trends in terms of providers and payers vertically integrating in terms of ACO, we'll start aligning incentives toward that patient and gaining more of that information and for people to do the right thing around that patient. So I think, just all of these things will drive healthcare toward more of a disaggregated level, disaggregated industry, and more of a market force-driven industry.
That raises a very important and integral question, I think, that we're gonna find out in the next 5 to 10 years, which is there are two sides of it that you could consider, and I think market forces will figure it out for us. Do patients want this kind of access? So the majority of patients, there are those quantified selfers, I'm one of them, and people that are really interested in all the data that they're collecting throughout the day with their Fitbits, with their GPS watches when they're working out or whatever it is. Are those more the exception to the rule, or are there more people out there that would take advantage of this if it were available to them? What we've seen with Google Health's failure, for instance, was a lack of people logging in and storing their own information because they just don't know it. I was diagnosed with asthma when I was 5, and I couldn't tell you the brand or the strength or the dose of the inhaler that I carried around for 25 years. So when it comes right down to it, what we're seeing, and what I would argue that we've seen, is that people don't take care of their health until it's too late. And we will determine the answer to the question, which is that because they don't have access to it, or because people just intrinsically aren't going to take care of themselves? With the incidence of diabetes going up as quickly as it is, unfortunately, I think we may be leaning toward the former, that they just
So I would
care.
ask Shadaab, you're obviously representing a very large health system. What's Kaiser's view on giving patients more access or control to their information, and do you see that improving care or customer satisfaction, or do you feel pressure from the patient community to have that access?
So first of all, I have a deep amount of respect for the question the gentleman from Stanford raised. I think it's a great challenge that they have put together to us to look at us as an industry which is a laggard industry in terms of adaptation of a lot of things. So and the areas that we are trying to look at the best practices within those within the best areas or the industries that have matured. Quality and safety are one of are specifically airline industry is a modeling in that way. So we are trying to get to mimic to that kind of environments. So that could be one of the responses that you would be looking towards. Nevertheless, there is the regulatory pressures, the consumer orientation and the understanding about that kind of impact was not really out there, and that was all based upon data until we came to know about the number of deaths that happen every year. And whenever we have a death number, that somewhat kind of strikes a chord with us, and once we come to know about that, we start basically reacting towards that, going to the consumer part of it. So if you notice, and since all of you are within the Bay Area, and some of them are basically traveled, but they're somewhat familiar with the Kaiser model. It is one of the organizations which is mostly on the forefront of technology from a consumer engagement perspective. So we have enabled the physician and clinician as well as the patient somewhat similar by utilization of the tools where there is an interactive dialogue that goes between the patient and the physician, and at the same time the patient is much more in control of their chart. They are much more interacting in that way, and then hence they are participant in their care processes. So not to say that we have reached the ultimate there. We are, it's a continuous improvement process where we have a lot of innovation that takes place. There are multiple centers of excellence of developing that innovation that is taking place within the organization. If you folks have heard about the Gulffield Center for Innovation, that is one of the biggest examples where we look at the challenging technologies or the upcoming technologies and incorporate them, and those technologies are not only clinician facing but more on the consumer side of it. We totally realize the value that it brings and the participation that it brings. You know, we are looking for on health as from a total health perspective. We're not looking at it from an episodic care perspective, because that's where we feel that if you have the total continuum of care, you have a healthy population. That means that if you are taking care of the child in the house, you have to take care of the mother in the house also. So that's the total concept of total care that we are trying to encompass.
Let's ask. We had a few. Let's open it up to more questions from the audience. There's a question here in the.
I would really appreciate the panel to separate out the issues regarding wellness information. Excuse me. I just want to see if the panel could address the issue from the standpoint of separating out wellness information versus, healthcare information that is specifically under HIPAA and other regulations. Because I think a lot of conversation here, if we separate those into two things, then the notion of innovation applying to each could be a little bit different. I came of age in the time of factory automation. So when I first graduated from college, I worked for General Motors in manufacturing technology. This is where the rise of ERP, MRP, and the rest of that, and the ripple effect of that through the world, in addition to the internet. So I think there's a lot of parallel here, but what happened here is that anything that related to healthcare governed under the insurance company, the Medicare payment, the regulations. So the rise of the wellness industry, I think, played a big role in this. And I think if we lump both of them together, then it becomes a confusing conversation, at least from my perspective.
I think there's some benefits in combining them, though, because if the suggestion to get better, and here's an app, here's a device, and here's how you can do it with a nutrition plan and an exercise plan, if that comes from your physician, you're much more likely to go do it. If there's a dire situation that they're trying to nudge you in the right direction for, or they see early indicators that you are pre-diabetic or you're pre-hypertensive, you can go tackle those things early. And if the education that you're receiving about how to become more well, about how to improve your health, comes from your physician and is available right next to your clinical information, then it becomes more real. It's almost like you're being prescribed. Most people go and pick up the meds that they're prescribed. Compliance there isn't as high as we would like it to be, but with electronic systems it does get better. If you are also prescribed a device or a mobile application from your physician, you're much more likely to use it. And if the cost is extremely low or subsidized by your insurance plan, we're much more likely to see patients take better control of their health. So I would say that there's actually a great benefit in combining them. I think Rebecca may have a different perspective.
Yeah. I think my view is one that feed to the other. The issues here, I think for the longest time, a lot of people did go out and test for HIV positive because they're afraid if that show up to their record, then the insurance company can take action against them.
So
what people feel
all right.
blood pressure right now is their way. So this is where I thought the wellness information feeds very well into the physician system, the healthcare system. But doctors are overloaded. Most of them even don't take the computer.
So
the broken part of that, though, is where reporting something or getting information that will make you better, and the perception that it will increase your premium costs, and actually wasn't much of a perception, or it was actually reality before the Affordable Care Act passed. The way you fix that is by forcing insurers to not raise your premiums. And potentially coming up with a public option, but I won't get too political here.
Also, there are ways to get around certain problems. I think in terms of the data that people are collecting outside the hospital walls, currently is wellness, just because there's money to be made, and there seem to be ways that people could get paid to do so. But you could collect things in terms of diabetes, even in terms of HIV, social media, all of these other things. You could collect all those information. They're not under the guidance of HIPAA. And how we get around that problem is, we have a great social media where millions of people are interacting. It's all anonymous. people, actually 70% of the people choose to make their data public so they could compare with each other. So the employers won't have access to that. So they get great insights in terms of comparing data with each other as well. So I don't think if it's really wellness versus healthcare system, it's in terms of how do you interact with each of those components to get the relevant data to the right people, but at the same time protect the privacy of that consumer.
We have a question over here. Go ahead.
So following along this thread, I guess this is mostly to Shadaab. Since you're seeing both sides of it, and if you see a patient that you would benefit from getting wellness information, you take like the scale that Matt was talking about, buy it for them, put it in their house, say use this every week, and we're going to decrease your premiums by $20 a month because you're not going to come in for heart surgery in the next 5 years.
So let me take it from a value perspective, that probably would be easier to understand in the larger context. Aetna Healthcare just recently did an app which basically looks at your medications, and going back to the point where you were not able to look at what was the dosage that you would. So it basically looks at your medication, history and trends it, and then from a trending perspective it kind of gives you what level of dosage you're taking, what are the medications you're taking, which kind of and continuously suggests you back. So from a value perspective, there is already an inherent value that comes out both to the patient as well as to the care provider as well as to the managed care organization, where there is the perspective of cost saving as well as managed performance of that patient within that scenario. So yes, there is a value that comes out for all three people who are participants in the care process. Does it answer your question?
It's a pretty indirect financial benefit to the patient. In an organization where it combines both the payer and the provider side, you could do it much more directly. Money's a good motivator, right?
Indeed, it is always.
Okay, I think we need to wrap up. I think we're out of time at this point. I'd like to thank the panelists. And
let's take one more question from them.
So go ahead.
So it's interesting, the panel has different perspectives on patients and managed care and doctors and data aggregation as to ways in which you can improve the quality of healthcare for the patients. And my question to you folks is, from your perspective, which do you see to be the tipping point? Is it the patient engagement? Is it the tools like MedHelp? Is it the managed care platforms that are created by Kaiser? I mean, which are the critical components that need to be there in order for things to tip so that people do start getting better and healthier? And people, in the recent Newsweek front cover this week, it shows this kid saying, "Help, I'm going to become 300 pounds when I get older." So this has become such a ubiquitous problem here in the U.S. today. So what's your perspective on that? I'm really curious, like, you guys are in the middle of the game. What do you think are the most important components to make a successful and impactful change?
Whichever of those incents the patient directly to take control of their health, because doctors don't have time for it.
So my perspective on that is, which is Kaiser's new process, we walk, everybody walks. Basically, you become a partner in that, and until and unless you don't have the total health perspective into it, you're still treating one aspect of the process, which basically means either you're treating the financial process, or you're treating the technical process, or you're treating the human process of engagement into it. So from a total health perspective, I think which kind of leads to this topic was how this information is basically integrated and then interconnected so that it becomes intelligent information. And that is where I would look at it as a holistic view on it, where you have to have all aspects of it covered. Now the problem probably which we continuously pose back in our minds is this is not connected. So how can we get to that? And I think the hope is that eventually, with all of the capabilities that technology offers and the innovations that technology brings, we are able to connect to that. Nevertheless, we should not undermine the importance of the processes and the human aspect of it. So it's a collective approach, it's a collective creativity that needs to happen in that.
Yeah, I think innovation is going to come from every angle. So for Kaiser, it's going to be different than independent practice working within this. So I think just aligning the incentives in terms of structure, focusing on what value you bring to the consumer, and getting that consumer engaged in terms of asking for that kind of information to know what the advice is, so their attention and motivation is aligned. I think that would be important.
Great. Well, I think that wraps it up. Thank you very much.
Thank you.